Okay, let's dive in. We've got this collection of sources, articles, research bits, personal accounts, and they paint a really compelling picture, sometimes quite challenging, actually.
Yeah, about healthcare innovation and, well, the kind of resistance you can hit inside these big systems.
Exactly. So our job here is to work through it all, pull out the key insights, and really understand the story, especially focusing on Dr. Katyali Srivatsa, his experiences, his ideas for healthcare, and what it all might mean for, well, for us.
And what really jumps out from these sources is this clear storyline,
Hmm.
identifying a really deep problem, proposing a pretty radical solution, then facing, significant institutional pushback.
Yeah.
And then the sources lay out these potentially huge global consequences if things don't change.
Yeah.
High-stakes stuff.
Absolutely. So let's start with that problem. The one Dr. Srivatsa apparently saw working as a doctor, particularly in the NHS, according to these materials. What did he observe?
Right. So the sources detail his concerns going back quite a way. He was seeing what he described as misuse and abuse of antibiotics.
By doctors.
By doctors, yes. And often this was linked to patients not being clinically examined properly. So you end up with incorrect antibiotic treatments being handed out.
And the materials show he was quite specific in his criticisms. He points to doctors using these really vague labels, doesn't he? Like URTI, LRTI.
Exactly. Upper respiratory tract infection, lower respiratory tract infection, UTI for urinary tract infection, or even just cold or chest infection. Vague stuff.
And then prescribing antibiotics based on that, unnecessarily.
That was his core criticism. Relying on quick things like a dipstick test for a UTI, maybe just taking a temperature, instead of actually listening to the patient telling their own story of the illness. He felt that was, moving away from proper medical practice.
And there's mention of a specific concern from 2004 about nurse practitioners and prescribers. What was that about?
Well, the concern outlined in the sources was that in these nurse-led practices, these walk-in clinics, incorrect diagnoses and treatments were happening, given by nurses working independently.
Right, so questions about maybe training or supervision.
That seems to be the implication in the material, yes. The scope of practice without direct oversight.
And this didn't just fade away. There's a key point mentioned in 2006 involving the health secretary.
Yes, Patricia Hewitt. She licensed nurses to prescribe drugs. And Dr. Srivatsa's view, as presented here, was that this move led to, and I am quoting from the material, substandard, unethical medical care.
Strong words.
Very. He clearly felt unsupervised nurses were prescribing potentially outside their expertise.
And this wasn't a new frustration for him, was it? The sources mentioned him challenging junior doctors way back in '96 about using pre-printed forms.
Yeah, assessment sheets. He felt it encouraged ticking boxes rather than, truly understanding the patient in front of them.
Okay, so if we tie all these observations together, it feeds directly into this huge global crisis we hear so much about, antimicrobial resistance.
AMR.
The superbugs, yeah. That's the big picture connection made in the sources.
Just to clarify for everyone, what is AMR based on the research here? Simply put, it's when the germs, bacteria, viruses, fungi, they evolve. They develop the ability to basically defeat the drugs that were designed to kill them. The sources call them superbugs.
And how do these practices, Dr. Srivatsa was worried about the unnecessary prescriptions, the quick diagnoses, how do they fuel AMR?
Well, the research is very clear on this. Overusing and misusing antibiotics in humans is a massive driver. Every time you give an antibiotic when it's not needed, say for a virus.
Right, where it won't work anyway.
Exactly. Or you use the wrong one because the diagnosis was rushed. You're essentially giving the bacteria more chances to encounter the drug and figure out ways to survive it. It speeds up resistance development.
And the scale of this, the stats presented in the material are, well, they're quite alarming.
They are stark. Globally, these resistant germs are now directly causing over 1 million deaths a year. And they contribute to maybe 5 million deaths total.
Wow.
And in the U.S. alone, the sources state over 35,000 Americans die annually from these infections. That's a significant number.
And part of the problem is we're not finding new antibiotics fast enough to replace the ones that are failing.
Precisely. Developing brand new classes of antibiotics is incredibly difficult, slow, and expensive. The bacteria are just evolving resistance much, much faster than our drug discovery pipeline can keep up. We're genuinely running out of options for common infections.
Okay, so Dr. Srivatsa sees these, well, deep systemic flaws, this looming superbug crisis. And his response, according to the sources, is Dr. Maya GPT.
Yes, Maya is presented as his answer. An AI-assisted tool but designed to be simple, really aimed at empowering people, particularly, the sources mention, those who maybe can't read or write.
Hence that slogan, your voice, your health, your power.
Powerful, isn't it?
And the way it works, the functionality described, sounds quite comprehensive.
It does. The core idea seems to be improving communication and access, so users can enter their symptoms. There's an example where you put in 3, and the app asks for more detail.
Trying to get that richer patient story he felt was missing.
Exactly. And it connects you to information from your own doctor, lets you talk to healthcare professionals 24/7, handles appointments, video calls, emails, prescriptions.
And it can even link into hospital systems to help digitize things.
That's a key potential benefit mentioned, yeah. Systemizing healthcare. Plus, it offers educational resources, videos, info sheets on common problems, aiming to reduce wasted appointments.
The list of potential benefits is pretty long. Empowering patients, making doctors' lives easier, cutting costs, fewer wasted visits, maybe less admin staff.
Reducing cross-infections by keeping sick people apart when possible, helping track infections.
And it's adaptable for poorer countries, emergencies, pandemics.
That's highlighted, yes. And crucially, the sources state he and his colleagues are offering Maya free as a humanitarian service.
Okay, let's circle back then. The original problem, antibiotic abuse, poor diagnosis. How is Maya meant to directly tackle that?
By guiding users to give detailed symptoms, structuring that information, the idea is to move away from those vague labels and quick tests. It helps capture that patient narrative. And the hope, presumably, is that this leads to a more accurate initial assessment, which, in turn, could mean fewer SNAP diagnoses and therefore fewer unnecessary antibiotics being prescribed. It addresses the root cause he identified.
It sounds like a very integrated approach, addressing communication, diagnosis, patient knowledge, system efficiency, all feeding into the AMR problem. But then the story in these sources takes a sharp turn, doesn't it? Describing the reaction he apparently faced.
Yeah, this is where the narrative really highlights the institutional barriers, what the sources call the elephant in the doctor's room, the resistance to change, especially when it comes from within and challenges the status quo.
And the accounts describe some pretty serious personal consequences for him. It says he was put under a discriminatory investigation for a year.
Yes, and the timing mentioned is significant. It was after he raised those concerns about the nurse's actions, the prescribing issue.
So after making what sounds like a protected disclosure about patient safety concerns?
That's how it's framed in the material, yes. Concerns about unethical practices, nurse prescribing, quality of care, and following that, this investigation.
And it wasn't just the formal investigation. There's mention of harassment, humiliation.
Ostracization, yes. The sources paint a picture of significant pushback within the institution. His perspective, as reported, is that the NHS showed contempt for doctors who raised flags or tried to innovate.
And actively tried to stop them sharing information, even if it was in the interest of, well, humanity's health, like with superbugs.
That's his stated view in the sources, yes.
Yeah.
Particularly regarding these systemic problems and the AMR threat.
This all culminated in a legal case, Srivatsa v. Secretary of State for Health.
Correct, against his former employers. And his perspective, conveyed strongly in the material, is that the NHS politicians, the Secretary of State, actively tried to stop him from pursuing this case.
Why? What reason is suggested?
He implies, according to the sources, that it was directly linked to those unethical actions. He challenged specifically the licensing of nurses to prescribe. The material quotes him saying they tried to stop him because they had a lot of skeletons in their cupboards and knew he was pushing for change and justice.
And he plans to appeal to the Supreme Court.
That's mentioned, yes, which underscores the length and difficulty of this fight, as described in the sources. It suggests a deep-seated resistance.
So just to summarize this part, he identifies major problems, offers a free solution like Maya designed to help, raises concerns about practices like nurse prescribing, and the reported outcome is investigation, harassment, institutional pushback, and a major legal battle he feels is an attempt to silence him.
That's the narrative presented in these accounts. It highlights how challenging established protocols, especially ones with political backing, can be, even when public health is potentially at stake with issues like AMR.
Which brings us right to that critical point, the wider consequences, the potential costs and problems for all of us, for humanity, if healthcare systems don't change, if they resist solutions like Dr. Maya GPT and don't address the issues raised.
And this is where the sources issue a really stark warning. The superbug threat isn't some distant possibility. It's described using terms like a tsunami that could, quote, wipe millions of people off the face of the planet.
Wow. And the argument is that the very practices Dr. Srivatsa criticized are helping this happen. The reliance on protocols over experience, unnecessary tests, patients may be self-medicating or not knowing enough.
Exactly. Those factors contribute. And then the kind of institutional resistance described in Dr. Srivatsa's case, that resistance to adopting new, potentially better approaches, it perpetuates those risks. Ignoring the critiques, maybe suppressing the innovation, it leaves us all vulnerable.
And the costs of not acting as laid out here are just devastating, aren't they?
Absolutely catastrophic. We're talking rapidly increasing deaths from superbugs every year, longer hospital stays, which means higher costs, lifelong disabilities for survivors, huge economic burdens on countries.
Not to mention the unchecked spread of these infections and failing to prepare for future pandemics.
Right, and you contrast that grim picture with the potential benefits described for something like Maya. Protecting healthcare workers, saving lives, improving care, cutting costs, empowering people, especially the vulnerable, globally.
So, when you look across all this material, the argument becomes really powerful. Failing to fix these systemic healthcare issues, resisting innovation like Dr. Maya GPT, it's not just inefficient. It could be genuinely catastrophic for our ability to handle the superbug crisis and whatever comes next.
It prevents the kind of ethical, efficient, effective healthcare system we need. The material suggests inaction isn't just passive, it's an active choice to stay vulnerable.
So, wrapping this up, what does it all mean? We've explored Dr. Srivatsa's really deep concerns about healthcare practices, particularly around diagnosis and antibiotics. We've looked at his proposed solution, Dr. Maya GPT. We've seen the significant institutional resistance he reportedly faced, potentially linked to his protected disclosures. And we've heard these dire warnings about the superbug crisis if we don't adapt. It really poses a fundamental question, doesn't it? Given this documented threat of antibiotic resistance and the potential for tools like Maya to radically improve things, what are the real costs? Not just money, but lives, societal well-being, when institutions maybe prioritize defending the way things are, resisting change, even when that change is offered freely, designed to protect all of us? What's the biggest takeaway for you from digging into these sources?